All right. Hi, everyone. Thanks so much for joining our webinar today. My name is Christine Burke, and I'm the Director of B2B Marketing at Healthy Careers. I'm so excited that you're taking the time to join us today to learn how to incorporate telehealth into your current staffing strategy. With today's challenging physician recruitment market, hybrid staffing models that utilize the best of in-person and telehealth care delivery can help. Today, we have two experts from locumtenens.com who will be sharing the benefits of hybrid staffing models, how to assess if they are a good fit for your organization, and how to implement them. So before I introduce the speakers, I'd like to quickly go over some housekeeping items. If you can change the screen.
Well, let me go forward. Let's see, there we go.
So first, we're recording today's session and we'll be emailing it to you next week. So you can either rewatch it or share with your colleagues. And we encourage you to submit questions throughout the session using the Q&A button at the bottom of the screen. We'll try to address all questions live at the end of the presentation, but if we run out of time, we'll be sure to follow up with you directly. So who's speaking today? We have Dr. Pamela Ograbisz, who is the Associate Vice President of Telehealth for locumtenens.com. She joined the company in 2018 and was responsible for the oversight and direction of all telehealth initiatives. Her clinical expertise combined with her past telehealth experience ensure that clients and providers are well supported with standardized and consistent best practices. She is also a board certified family nurse practitioner and specializes in cardiothoracic surgery and internal medicine. She's joined by Matt Littlejohn, who is a senior provider enrollment specialist at locumtenens.com. He works to simplify enrollment for clients, show them the true value of proper enrollment, and help them realize it is not as difficult as they think. Matt has been with locumtenens.com for almost 4 years, and he previously worked for Apollo MD, which is a practice management organization where he was responsible for enrolling clinicians and ensuring millions of dollars were able to be billed successfully. After seeing how large of an impact enrollment has on everyone involved, Matt found a true passion for educating individuals on this subject. So without further ado, thank you so much for joining us, Pamela and Matt. Let's go ahead and get into it.
Christine, thank you so much for that lovely introduction, and thank you all for joining us today. My name is Dr. Pamela Ograbisz, and I'll be the first speaker today, and then Matt will join us in just a bit. To tell you a little bit about our company, locumtenens.com was founded in 1995. We've provided thousands of healthcare facilities across the United States with innovative and strategic approaches to staffing. And we've delivered care to more than 7 million patients in over 4,000 healthcare facilities nationwide across 60 different specialty lines. LT Telehealth is an internal company inside of locumtenens.com that I run. So we develop all of the telehealth programs, and then they are staffed by our LT physicians. We bring comprehensive, cost-effective solutions to the clients that we serve. We do both on-site and hybrid coverage, and we have full technical support with 24/7 in-house technical services. So let's dive right in with an overview of how telehealth can benefit your clients. The first is certainly an increase in your regional market share. So you can increase the profile of your facility by offering this benefit. It will also garner you more patients. I think that during COVID, patients became very, very comfortable with utilizing telehealth opportunities. And now what we're seeing from survey data is that they are disappointed if those benefits are being removed or if they don't have access to them at the facilities that they are choosing to utilize. For population health, and for those of you that are not familiar with that, this is a really big buzzword, amongst insurance providers, but telehealth really improves the health of any population that it serves. There's 4 main pieces that go with population health, and the first is an emphasis on access to primary care. So telehealth really redefines the way that you can look at serving your clients with their PC benefits, as well as how you can garner them some access. Collection of data, so reliable data to spur health changes so that patients actually can log in and use perhaps their MyChart opportunity to watch their labs, track their sugars, and really have an interactive experience with their providers. Provider leadership is another big piece of this. We know that lots of doctors, nurse practitioners, PAs, nurses really approve and enjoy utilizing telehealth as a way to manage their patients and see their patients. It's a positive interaction. And the last is, of course, continuation of healthcare beyond the four walls of your facility. That has always been such a challenge, right? The patient leaves the office and then we don't see them again for 4 weeks, 8 weeks. Sometimes, we lose them for months on end. And so where is the connection in the follow-up? And telehealth really does help engage and solve that problem. Telehealth does provide a new revenue source. So you're able to offer new programming through this opportunity. And of course, a value cost savings by hopefully decreasing some of your brick and mortar overhead. For access to referrals, if you don't currently offer, specialist care, so cardiology, oncology, dermatology, these are all easily brought to your facility through tele, and it doesn't have to be a full-time opportunity. Perhaps you don't have the volumes to support those programs currently, but you could bring them in weekly or maybe bi-weekly so that patients do have access to these opportunities and don't leave your facility to go somewhere else to obtain them. You can also participate in accountable care. So, effective healthcare with a focus on the bottom line, who delivers on patient-centered care, and of course, addresses provider burnout. I can tell you that as an actively practicing NP, I do really enjoy the fact that I am able to use this modality. I'm employed full-time here, but still do see patients pro bono. And it's lovely to be able to have kept those connections and do it virtually, where even though it may be on the weekends, I'm sitting in the comfort of my home and offering, value services to clients that definitely need it. So what are the keys to success for you to implement a program? So if you've not done this before, the initial steps really would be to analyze your current situation. How are you going to make this program work? Why do you want it to work? What specialty lines are you going to put into it? You need to look at the model that you would like to deploy. Some of our clients say, yes, I want this 100% telehealth. So that means that whatever provider is going to be behind the screen will never step foot on site, perhaps outside of training. Others have opted for hybrid options, which is where, based upon the clientele that's being serviced, the doctor and PPA will come on site for a certain amount of time and then be tele for a certain amount of time. We'll actually cover a case study in a little bit for oncology where we rolled out this model and it worked beautifully. The other piece would be, what kind of equipment do you require? So are you a large hospital that needs mobile units and carts? Are you a small clinic that could deal with static workstations on a desktop? Do you have limited space and really you're just going to use an iPad and pass that around? Would you prefer a mounted system on the wall that has, pan, tilt, zoom cameras? Right now, there's drivable robots that are available. The sky is the limit for the kind of equipment that you could utilize. But what I can tell you is this: it does not have to be fancy in order for tele to work. So I think people sometimes automatically associate equipment with a heavy price tag, and it really does not have to be that way. The next piece would be to review your infrastructure. And this is primarily looking at your bandwidth. So, how are you transmitting data within your facility? Are you using ASL, DSL, fiber, cable? And how much of a signal are you able to carry through on your current computers? Do you have to upgrade those systems? And last but not least this is certainly a heavier technical lift. If you don't have internal tech support, that is something that you may want to look at, or perhaps farm out to another organization where you do have someone at the ready to help you if something isn't working properly. To continue on keys to success, or once you sort of go through those initial steps, these are some other building blocks that need to be reviewed. So you need to understand the full scope of the expectations and the buy-in from the sites that will utilize your solution. So are you looking at doing this at one site, 5 sites? Are you a hospital system that will deploy this throughout multiple critical care units? deciding where you want to do that is important because programs need to be tailored. And then that rolls right into customizing programs by specialty line. Programs that I build for oncology look completely different than programs that I build for cardiology or psychiatry or neurology. So it depends upon what you're looking for and what you're trying to achieve as to what kind of system you need, the amount of support you require, and then, you know, figuring out the sort of the bare bone details to get those things stood up. Implementing processes and procedures that ensure quality and safety are essential. That's a big piece that we work out when we look at workflow. How will a doctor be plugged into the system? How will they communicate with the staff on site? How are they going to get access to charts? How will they put in orders? What happens if communications go down? All of these pieces need to be addressed so that you have proper plans. All right, clinician availability. A big piece of this is what type of coverage are you going to be looking for? Are you looking for a 24/7 model? Are you looking for interim coverage? Are your clinicians licensed properly? For those of you that don't know, you do have to hold the license of where your patients are sitting. So right now I'm sitting in Georgia, but if I were seeing patients in Virginia, I must hold a valid Virginia license. And then you also want to make sure that your folks are practicing in a proper environment, right? So it doesn't necessarily have to be an office space. It can be from a home office, but all of those pieces are essential. You can't be taking calls in the middle of a Walmart. And then last is a single point of contact for the program, making sure that whoever your doctors are utilizing, whoever your nurses need to get a hold of for the day, that they can do so and they know how to do so easily and quickly. Some quick telehealth do's and don'ts. And essentially, you want to focus on the patient experience. That is the most important thing of when you set up a program. So you want to make sure that they have proper access, right? Are you doing this where they're going to be logging in from their homes? Will they come into your brick and mortar and actually maybe be touched by a nurse, have vital signs, sit down in a dedicated telehealth room, and then the doctor or the NP or PA is virtual? What does that experience look like for them? Does that make them happy when they do it? And what is the engagement like across the screen? How, does the patient feel that they are really fully a part of the experience? And you do want that to happen. You need someone on the other side of that screen that is engaged with the patient, but also has proper bedside manner and knows how to deal with sometimes the hiccups that happen with telehealth. A screen goes down, the volume doesn't work, the patient's not seated properly, their camera's not, pointed in the right direction. Someone who can walk them through and fix those problems. You need to determine that the patient and their concerns are proper for a telehealth visit. And there are some things that are not proper for telehealth. So for example, we work with a tremendous amount of psychiatry clients. There are some units where the patients are so incredibly sick, or for example, schizophrenic patients, this is a tough medium for them. They are already suspicious and concerned about television screens, people watching them. So this makes it for a very, very hard visit. So when you do plan out your program, you want to make sure that the patients you're going to be servicing actually will benefit from telehealth. The provider must have the proper skill set for performing telehealth visits. While I don't think that there's a tremendous amount of training that has to happen, the doctor or the provider on the other side does need to know how to use their equipment, how to toggle between screens. They do have to be adept at charting, usually while they are seeing patients, which can be more challenging when you're doing telehealth versus being in a room, because sometimes your gaze shifts and it really appears as though you're not paying attention to your patient at the time. So having that proper bedside manner, knowing that what questions may arise from patients on tele does take some time, energy, and effort to get comfortable with. I would also say that lighting and camera angles and attire matter. While we don't necessarily say that you have to wear a uniform, you certainly have to be dressed and properly. Sometimes, you stand up to get something, we need to make sure you're not standing in your underwear. You have to have on, certainly the proper clothes for what you're going to be doing. And then lighting and camera angles. I think that this actually is not addressed enough. We have all been on Zoom calls, Teams calls, where cameras were pointed in the wrong direction. The lighting was terrible and you couldn't see someone. And that's really, really important when you are providing, critical care for patients who need it. So we ensure that those are done in test sessions with both the site and the provider before we start. Now, when you have patients who are accessing this service from home, sometimes that can be compromised, especially if they're on phones. So you do need to make sure you have a checklist to walk through with your patients, that they're in proper environments with good lighting. And the last is you need to be mindful of the laws and rules that go with practicing in this medium. So as I said, you need to make sure that your docs are licensed in the proper states, folks have their appropriate DEAs, that they are accessing and utilizing EHRs as they should be, and that they're sitting in proper environments. So just to give you an example, if you are choosing to bill Medicare for services, right now Medicare does not allow providers to practice outside of the United States and bill for their services. So if you have a doctor who chooses to go and practice in, let's just say, Southeast Asia, and then they would still like to work and see patients, you will have a hard time billing for those services. So you need to make sure you check all the boxes. I did want to review a case study with you that was very interesting that we had the opportunity to help a client with. This is a small Michigan hospital. They're full service with a full ED. They are in a rural location, and they had a very small pool of oncologists that were available to them, and they were struggling to provide appropriate care to their patients. I think they had 3 to start, 1 retired, 1 took a different position, and they were left with 1 remaining physician. We tried very hard to source a full-time boots on ground replacement for them, and we struggled significantly, but we had a lot of interest in people who were willing to do it part-time. And so we had, I think, a very open and honest conversation with them about the fact that we felt that this could be accomplished if we did a hybrid program. We found a wonderful, wonderful oncologist for them who now flies in and stays on site 2 weeks out of the month, and then the other 2 weeks works from home. During those 2 weeks that he's on site, he's seeing all of his brand new patients and all of his very complex follow-ups. Or if he's delivering significant news, we try very hard to make sure that those patients are scheduled at that time. When he's home, he is overseeing the infusion centers, and he is just having general follow-ups, going over labs. There is a slate of nurse practitioners that work there that he also consults with and helps with their cases. So it has really been a beautiful partnership, and it's been quite successful. As a matter of fact, we are looking at now standing up another hybrid physician for them to do the exact same thing. It's truly the best of both worlds. I think that the benefits of this, you're able to cover complex cases, improve patient satisfaction. The patients have been very, very pleased with the opportunity because they have a good, solid connection with their doctor. And I think a lot of people say, "Gosh, this is oncology. This is very tough, heavy stuff." And I would agree with that. But I think because they are able to meet with him in person, and then when they see him on the screen, they already have that established relationship. Will also tell you that as a provider who, works 100% remotely, I meet a lot of my patients for the first time across the screen. Once you see each other a few times, you really do develop that bond. Again, if you have the right personality for tele. This did improve physician morale, both for the physician that they had on site and for the physician that wanted to do the job, but just did not want to be away from their family for that amount of time. So we really, again, were able to put together a wonderful solution for this client. And I think that the program deliverables that came out of that is we provided continuity of care. The big piece of this is that when they had spoken with other agencies, they could staff them, but it was going to be this just rotating, revolving door of doctors coming in and out. And I think that when you really think about oncology patients, if that were you, would you want to see a different face every other week and then have to restart and re-explain, what you've been through? So being able to deliver the same doc every single week, month in and month out, very, very important. And telehealth certainly helps us do that. We tailored this program based on the facility's exact needs. What I built for this for this hospital is not what I would build for a different hospital. So again, you have to go in and know exactly what you want and make sure that it fits the patients that they're serving, as well as the staff that are on site. So when we hired this doctor, he actually interviewed with all of the staff to make sure that they would get along as well. This provided shorter wait times and turnarounds for consults and follow-up appointments, which I think is obvious, right? They had gone down from having 3 docs to 1. So this certainly increased their ability to see folks, but they've also become more efficient because I think they've relooked at their scheduling opportunities. And so they really maximize the time that the docs are in the office and also when they're not in the office. This really prevented them from losing patients who were starting to seek care elsewhere. And it wasn't exactly close for them either. It was quite a drive if they were going to change facilities. So not only did we help this facility, but we helped their community. And we certainly improved the patient and provider satisfaction. This is just a little bit about what our clients are saying about us. So avoiding patient transfers. For one facility, we want to get them home as soon as possible. We try to medically manage patients in-house, so we don't have to send them to acute care. If we can prevent that, we can keep the length of stay down. These are all different clients where we've set up programs. Improved patient satisfaction, improved the speed to care, and certainly the access. And I think that that's probably the biggest piece that I have seen with when we've built telehealth programs. We have been able to truly increase access to so many specialty lines where patients were unable to either get in an appropriate amount of time. They were having 6 to 8 month waits to get in to see a cardiologist, an oncologist, or neurologist, or they lived in an area where they had to travel upwards of 75 to 100 miles to go see a specialist. And I think that when you're really sick, that's a really tough thing to do. So telehealth really can improve lives in so many different ways. With that being said, that kind of wraps up the clinical side of how you set up programs. I'm very happy to turn this over to my colleague, Matt Littlejohn, the specialist with all things billing. So Matt, I'll let you take it away.
Thank you, Pam. Appreciate that. And thanks to everyone for joining us today. It's a pleasure to be presenting over this. So as Pam mentioned, my name is Matt Littlejohn. I'm a senior provider enrollment specialist at locumtenens.com. So now we know the keys for success in implementing a telehealth program and some of the benefits for doing so. So what comes next now? So first off, you want to ensure you can bill for these providers, both locum tenens and regular providers. We're going to kind of mix both in here, so you get some education on the locums world as well as the usual world. A lot of things are the same, a lot of things are different. So we're going to dabble in a little bit of both here. So first off, some facilities prepare to actually take a financial loss when they're needing a locum tenens clinician or help at all. Revenue is being left on the table when these facilities are unfamiliar with enrolling locums providers. You want to ensure that you are actually properly enrolling these providers, setting your practice up to successfully bill for telehealth and any medical services in general. At locumtenens.com, we came, we saw a change in the industry that kind of went away from the typical locum tenens billing, which we'll talk about in a little bit here. We saw a shift that required it going to full enrollment being needed versus just a way that you can bypass things. So whether the assignment is telehealth or not, I mean, enrollment is a vital part of the puzzle of getting a provider to work, making sure that our patients can get the best quality care possible. We see this in our daily work, with enrollment being the deciding factor on if a provider can go to work or not. Locumtenens.com and we've kind of made this our passion project, if you will. Educating others on how to properly enroll and then bill for services provided. It's a small part of a bigger puzzle, but it can have massive effects if you don't do it correctly. Also, another note that I've kind of discovered over the years is it's really hard to find information on enrollment and billing. There isn't a lot of conferences or webinars like this that you can join. So that kind of goes into the equation already with us wanting to do some things to help educate our clients and just the industry in general about how to correctly enroll and bill. So we can go to the next slide here. So understanding enrollment, Provider enrollment is the process of applying to health insurance networks for inclusion in the provider panels. I know we have kind of a wide range of people in this webinar, so I want to kind of start slow so we can get on equal footing, and then everyone can be on the same page. So first off, provider enrollment and billing are going to be two different things here. You might hear these terms used in the same sentence. You might hear them used interchangeably, but they are two very different things. Proper enrollment is actually going to allow you to bill successfully after the fact. So once a provider is successfully enrolled, you then move on to the billing stage. And that's when the whole billing process comes into play. And then the last part is maintaining the enrollment. Not only is this going to involve submitting the application, that's going to be navigating through the approval process. This can be very difficult. You can have an easy process or one of the most difficult processes. It's going to be different every time for you. Because you're mostly working with CMS, federal government, sometimes you're going to get the runaround, and you have to know how to adapt to the situation, fix the issues, and kind of resubmit that next application a correct way if you need to do that. This involves submitting the application, getting it approved correctly, revalidating that enrollment. So when you're actually submitting the enrollment, that's when the work is actually beginning on this. That's where the hard work is going to come in, the timely follow-ups and et cetera on that. Go to the next slide. So there's two types of enrollment really. We talked about implementing a telehealth program. So I really kind of want to roll this back to the basis of enrollment, give you the two types of enrollment that there are. It's kind of unknown in a lot of situations, but when a practice is starting, they actually have to enroll that practice in the group initially. When you set up a group enrollment, that allows you to kind of talk with the insurance payer, give them all the necessary information that they need for reimbursements, et cetera. And then after that group enrollment is approved, you're able to go to the individual provider enrollments. Now that group is being enrolled correctly, so they're going to get an ID, and all of the individual providers are actually going to be linked under that group. So there are two types of enrollment that you have to look out for. You can't just start a practice and start enrolling your doctors, because those claims are going to kick back because they're not linked to a specific facility or practice. Second type, obviously, is the individual enrollment, individual practitioners. And then that subsets into two types of enrollment. So we have billing or non-billing. This is what we see daily in the locums world. Their billing gives you full billing privileges. It's kind of in the title there. It allows the provider to prescribe as well. So when we're enrolling a provider, 99% of the time, we're gonna want to go for that billing enrollment. That gives us full freedom to bill. The second type is non-billing. It's often referred to as ORP, ordering, referring, prescribing. You may have heard that term. It's useful in certain situations when the provider isn't seeing patients. Maybe they're just prescribing. Then a non-billing would be good for that situation. So we need to make sure which type of enrollment that we're going after is the correct one, right? If we try to enroll as non-billing and then bill for that provider later down the road, that's not going to work out. So we have to kind of make a roadmap of which route we're going to take, and that'll help us later down the road. So to give you an idea of the financial impact surrounding enrolling a provider correctly, we have two statistics here. The average new patient and outpatient revenue for a physician is $2,387,727 annually. So let's assume that that physician works 235 days a year. The average daily revenue is $10,122. So this shows just how important enrolling a provider is and how deep of an impact it has on an organization if this is done incorrectly. Knowing information like this can help start conversations with the right people in your organization, ensuring that in the future, this gets completed in a timely manner and it gets completed the correct way to allow you to bill 100% to your capabilities and getting all of those reimbursements back. So obviously, enrollment doesn't just influence the financials. Nearly everyone is affected by enrollment that wasn't completed correctly, right? So we have obviously the first point is about billing in network. So if your group is not able to bill in network, the only other option is out of network, right? Those rates are going to be a lot lower from the insurance payers. So it's well worth your time to put in the effort to enroll providers the correct way and then bill in network. So something that I think doesn't get noticed a lot, and it's part of why this is made, it's my passion now. I've kind of found passion in this, is because one of the most affected people in this whole situation is the patient. So if a provider isn't enrolled correctly, a patient goes to see that provider, they're going to get an out-of-network bill because they weren't enrolled correctly with their insurance. Their insurance is not going to cover that in an in-network rate. So also this affects the patient's prescription. Sometimes we see this all the time in locums. This is usually tied to the state Medicaid program and them not being linked to the facility through the state Medicaid. So their prescriptions are going to be denied when they go and pick up medications. When they're feeling sick, they're trying to get their medications to feel better, and it's going to be denied. And this is all on the back end, and the credentialing and enrollment person's responsibilities and the patients are getting affected by this as well. Of course, these occurrences are amplified in a locum situation as the provider isn't a permanent provider at the group, quote unquote. And this causes enrollment to fall through the cracks more often than you want to see. And a lot of people are seeing the ramifications of the enrollment not completed in some way. It's pretty much hitting everyone. Even with the prescriptions, you can relay that back to the provider. If they're prescribing some drugs to a patient, they go to get that prescription, it doesn't go through, that patient's going to think, well, what's going on with this provider that I just saw? So it's really hitting all points. So it is important to correctly enroll that provider and make sure everything's going to happen correctly. So let's talk specifically about locums enrollment. I'm sure majority of you have had to deal with a locums provider coming on. It can be a lot at first. It can be really confusing, but it really doesn't have to be. So when you hear the term locum tenens billing, what exactly does that mean? In a situation like this, you have two choices. So you have the Q6 modifier or full enrollment. So think of it as coming to a fork in the road, right? The Q6 modifier is wonderful when you can use it. It's very hard to use. So the only way to use the Q6 is if you have a physician that's going on a temporary period of leave, of course, replacing that with a locums physician. So it's only physicians. You're able to bill using the permanent provider's MPI. So they're already set up at your group. They're already enrolled. You're basically billing under their direct MPI. So that allows your locums to come on for a temporary period of time, see patients, and you can bypass all of the enrollment work. Now, of course, the Q6 comes with a bunch of regulations that you actually have to hit. Your permanent provider that's going on a temporary period of leave must be unable to see patients at all. So this means they have to go on vacation or they have to continue medical education. They can't leave to another practice and still see patients at that practice. They have to be unable to see any patients. Also, another little quick note on regulations is they can't be gone for longer than 90 days already. So this has to be a pretty quick situation. You have a provider that's leaving soon, you have a locums coming on shortly after, and then you're able to use it. Now you can only use this for a period of 60 days. And this is where I was kind of mentioning that the locums industry is shifting a little bit because the Q6 was created for locums. The Q6 is locum tenens billing. And when you're unable to use the Q6, it's kind of like, where do we go from here? Now, a lot of situations, we've found out that a ton of our assignments are unable to use the Q6 modifier. So technically, that's no longer a locum situation. You're just onboarding a provider to fill additional shifts. So what do you do in that situation? So you would enroll that provider just as any provider you have on staff. That one word locums that is attached to that provider is going to confuse you like crazy, but don't fall for it because they are going to be enrolled as a normal provider. So they are enrolled as an individual within your group. You are able to bill for them just like Dr. John Doe on your staff. The reimbursement rates are not going to be different just because they're a locums MD. It's the same thing. They're going to be an MD just like any permanent MD on your staff. So let's go to telehealth enrollment. So one point that differs telehealth from other enrollments will be two sites here. The first one being the distance site. So as Pam was kind of talking about earlier, she could be in Georgia seeing patients in Virginia, right? So these distance sites and originating sites could be two different states. Distance sites where the provider is delivering service. The originating site is the location of the beneficiary at the time service is furnished. So a quick note here, not every insurance payer will have telehealth specific enrollment. It's very important to work closely with them and make sure that you are enrolling this telehealth provider using the necessary steps. For example, if you went to enroll him and you put the service address of just where the provider is, and you're not putting the originating site of when the beneficiary actually is, it's not going to work out very well for you in that case. So it's important to know both sites you need to input for telehealth. And it's also important that the provider, like Pam mentioned earlier, has the credentials in the states needed, because that's going to be very important with these insurance payers. They are going to want all those credentials. And if you can't supply the correct ones for a provider that's in a different state, seeing patients in Virginia, then the enrollment isn't going to be approved. So they're going to be very picky about what you supply them, and you have to make sure you have all the necessary credentials lined up. So some keys to success here. First one is to create a process for enrolling every provider, ensuring that you're able to bill. When you put a set process in, every provider that comes to work from then, you know that you're going to do the same process for every single one. So take note of your payer mix. So these are the payers that you credential with, that you've negotiated contracts with your managed care department. So if it's Medicare, Medicaid, and a mix of 5 commercial payers, right? When Dr. John Doe comes on, I know I'm going to enroll him with these insurances. So I'm going to kind of make a habit of it to work with these insurances closely. So every time I get a new doctor, I know what I need to do. Work closely with your insurance payers. I know with the federal government, state governments, and commercial payers, it kind of comes off sometimes as they're kind of against us. They're giving us a hard time when we're submitting these applications. But at the end of the day, we are on the same team. Our end goal for everybody is to get medical care to patients that need it. So work closely with them. You're on the same team. And when you get contacts at these insurance payers, that's another tip that makes it very easy to get your applications through a little bit smoother next time. So the biggest key of all, in my opinion, implement this process as early as possible, and that'll make things so much easier on everybody. When we're talking about enrollment at the very beginning of our assignments, before the provider is even coming on, we're going to iron out those issues at the beginning. It's much easier to iron out the issues starting off than to wait until there's a massive fire going on and say, oh, we got to get this provider enrolled today, even though he's been working there for 6 months. It's a lot easier to figure out issues at the very beginning. And then if you come across some roadblocks, again, you're giving yourself time to figure out a road map to get around those roadblocks. So now let's talk about CMS Telehealth Waiver 1135. So under this waiver, Medicare allowed reimbursements to be paid for office, hospital, and other visits furnished via telehealth across the country, even in the patient's place of residence. Pam mentioned earlier that with CMS, they require the patient have a prior established relationship with that particular provider. So mentioned as that hybrid telehealth program, he saw the patients in person, and then with follow-ups and stuff was done via telehealth. So prior to this, Medicare could only pay for telehealth on a limited basis when that person receiving the service was in a designated rural area, when they leave their home to go to a clinic, hospital, or certain other types of medical facilities for the service. It's kind of broadened the places that you could be receiving telehealth, and it really expanded telehealth as a whole. So now, whether you're at your home or you're at a medical facility, these visits are considered the same as in-person visits, and they're paid at the same rate under the public health emergency waiver. So it's been in effect for the entire duration of COVID, obviously, and it was just extended back in October. Right now, we're looking at the first 2 weeks, around the 11th of January is when this public health emergency is kind of slated to expire. So we're going to have to wait and see what happens with that. They might extend it again. or on the next slide, we can talk about some legislation that's in process. Fingers crossed this one gets pushed through. I think we can all agree that this is great for healthcare in general, especially telehealth. So House Bill HR 4040, it's called the Advancing Telehealth Beyond COVID-19 Act of 2021, but now it's also 2022. It was passed in the House actually on July 27th of 22, and it was referred to the Senate, and then they actually referred it to the Finance Committee on 7/28/2022. So it's been referred to the Finance Committee 2 times now. Still no word on this if this is going to get passed. But what this essentially would do is, even when the public health emergency goes away and that waiver goes away as well, this would keep a lot of the flexibilities from that waiver until the end of 2024. So they would still allow the beneficiaries to receive these services at any site, not just a medical facility. And it also allows a ton of types of providers to furnish these telehealth services, therapies, I mean, really anything. And FQHC and rural health clinics are serving as the distance site as well. It allows that to be done. So a lot of eyes are going to be on this in the upcoming weeks and months, waiting to see if this bill actually gets passed and signed into law. I know we're kind of moving away from COVID, so I don't know how long the public health emergency is actually going to keep on being extended. So hopefully we can get something passed that will extend all these kind of loosening of the regulations for telehealth. All right, so that's it for our presentation. Appreciate everyone joining. And with that, I will throw it to questions.
If anyone has any questions, please submit them in the Q&A button at the bottom of the screen. I haven't seen anything come through yet, but I did have a few questions that I wrote down while I was listening that hopefully will be helpful for others as well. So I loved hearing about the oncologist case study earlier in the presentation, and I was wondering if there are any other specialties that you think are especially well suited for a hybrid or telehealth solution that you've seen, like everyone's wanting to make this the norm in that specialty.
We have seen this actually, sorry, I muted myself, wanted to make sure I was back on. We have seen clamoring for this across, honestly, all specialty lines. We are doing this with cardiology, not interventional, but general medicine cardiology. We've done this with dermatology, oncology. We also have this with neurology and some of our surgical lines where the physicians are used intermittently to come in and supply relief, right, for the current operating teams. So they will rotate in and then they see all of their patients in follow-up via tele. So there's all different kinds of ways that you can truly meld tele into your your programs and make it functional. But really, for a lot of places, it's been sort of a lifeline of support. Right, we're going to use tele to help us to bail us out of a situation, and then they liked it so much that we've evolved the programs and made them a part of their regular offerings.
That's great. Thank you so much for sharing that. So we did have a few questions come in. Thanks for submitting those. One from Cynthia, who is asking, we have Medicare patients that live out of state for half of the year. Can we still do across state lines during the PHE?
So a little bit of a loaded question. So Medicare enrollment is separated by state. So let's say if you're Georgia and Virginia, I'll keep on using that situation. So if you are in Virginia, you're going to be enrolled in Virginia Medicare, Georgia Medicare. So you're going to have to be enrolled with the Medicare that you're being seen in. So if they are in Virginia half the year, right, they would have to be enrolled where they're being seen at in the state that they are. Yeah, so it kind of a difficult question there, but yeah, it depends on where they are at the time of being seen by the doctor.
Got it. Okay. Yeah. Minu asked, what kind of ideal technical equipment do you recommend for a provider, like 2 screens, and does the company provide it?
So it depends upon what kind of provider you are as to what you need. I'll give you an example. So we do a lot of radiology opportunities, and those physicians get from us a laptop with 2 additional 4K screens, which are meant to read mammography, CT scans, MRIs. If you are like with what I do, right? So I'm seeing follow-ups for cardiologies and also some primary care and internal medicine, and I do occasionally pop back into critical care. I have a basic laptop with an additional screen that I can toggle back and forth from. I have the patient and my camera on the large screen, and I utilize my electronic health record on my laptop. That's what's comfortable for me. I would say that some people really do like the 3-screen modality. So you have your laptop and the additional 2, but I do think 2 screens are a minimum. If you are doing a lot of primary care, you do need to make sure that on the other side of where the client is, right, that they have those appropriate peripheral opportunities for you. The Bluetooth stethoscope, a horoscope handle, which is a device that allows you to look down people's throats, look in their ears. The nurse or the MA that's handling those instruments for you is able to snapshot pictures of the ear, the throat, upload them, which is beautiful because you can keep them. And when you see them in follow-up, you can actually relook at the pictures instead of just your notes. It's really kind of fabulous. But if for just your side, if you're just talking about the provider, it really just depends upon what you're doing. If outside of dermatology and radiology, a basic computer and a screen would be just fine. I do recommend a high definition camera.
All right, we had a pretty specific question asked that I was hoping that actually that Matt is going to follow up with Alicia directly with you on that one. And then we had another question come in that's from someone that's asking, does telehealth work well for diagnostic radiology?
And I was just saying, so yes, we have docs that read all of the time, and we work with them, and they read on RVUs, and we work directly with some of those large radiology companies. They work across many different hospital systems, reading all different kinds of scans and screens.
Another question about, is there any guidance about how one should bill an encounter?
I would say with that too, we can probably follow up.
Follow up? Okay.
Yeah. Also, I would say with the first question with Cynthia, if you shoot me an email, we can kind of talk in more detail of what exactly that situation is, kind of discuss it in more detail. Happy to talk about it.
And Alicia, this session is being recorded, so we'll be sending it out early next week so you can rewatch. And we're also planning to share the slides in case those will be helpful for anyone. I know sometimes after webinars we get questions about whether we can share the slides, so we definitely will be able to do that. You'll get everything all in one email. And I don't see any other questions come through. And if you guys have any closing statements or any maybe questions that you get commonly that you think would be beneficial for others to hear, otherwise we can end a little bit early.
Absolutely. I think probably I'll just leave you with this, which is, I think sometimes we have a lot of clients who come to us who think that telehealth programs have to be overwhelming, and they really don't. I would pick a specialty line or two that's a pain point for you. Where are you struggling? Where do you not have the coverage that you need? Or where is there a service that you'd like to offer that you can't because you don't have proper volumes? And then you start there. It doesn't have to be a large scale program. We often do a tremendous amount of pilot programs where we turn things on for 12 or 16 weeks and we see if it works. And if it doesn't, you close it. I don't think this has to be a huge financial investment in the beginning. What it is truly the opportunity to determine if you can offer a more expansive set of services to your patients. And what I will say about the rules and laws and regulations that are coming down the pike, I do actually been very fortunate to be selected to sit on a lot of these committees. I'm actually headed to Washington shortly to talk about these. But HR 440 does look very promising, and I do believe that it will pass. On both sides of the aisle, doesn't matter whether you're Republican or Democratic, everybody wants better access to healthcare. We know that as a nation, we are unhealthy, and that we need to do a better job of making sure that we can see patients. So I do believe that we cannot put the genie back in the bottle from what has come from telehealth, that we will move forward. I do believe that they will extend the public health emergency probably at least one more time in order to give Senate and Congress time to, from the elections. If any of you have been living under a rock, we have a runoff going on here in Georgia. So we're just waiting to see, get those people settled in Washington. And then when they go back for session after the first of the year, my guess is they will extend PHE one more time, and then they'll have to do something about HR 440. But the way that we're seeing, and Matt can certainly speak to this, but the way that we're looking at Medicare and Medicaid, how they're leaning, what private payers are doing, it's not to remove telehealth services. If anything, they're looking for expansions, and we're seeing that with services that are being offered. So I do think that the telehealth, the future of telehealth is very, very bright.
Yeah, and I'll just say, reach out if you have any questions. I'm always happy to have constructive, conversations about this stuff, because I know it's very detailed, it's very hard sometimes, and it's difficult to find some information about this online. So reach out, and I'm happy to talk through your issues.
For sure. If anyone is interested in even discussing how you set up a program, we're always happy to help. And you've got our contact information on the screen.
Thank you so much for sharing all of this amazing information. I know it was super informative in every regard, legislative, the how-tos, the case studies shared. So I just want to thank you so much for your time today. And thank you everyone who was able to join. We really appreciate it. And I hope everyone has a happy holiday season. And we look forward to connecting soon. Thanks so much.
Thank you.
Thank
Bye.
you.